It's a great honor for me to co-chair this session with Professor Sharif Hafez and Professor Fawzi Mahfouz. And may I call on the first speaker, Professor Devaka Fernando from UK, who will talk about patient-centered diabetes care. Treat the person, not the disease. A wonderful slogan.
Good morning. It's lovely to be back in Egypt, and I thank the organizing committee for asking me back. Patient-centered diabetes care is the buzzword. I think we have to put the patient first, is what we have been told in so many lectures. I would prefer to use the word person, because sometimes it is a person with a disease because they may not feel a patient. It's an asymptomatic illness. They feel well. They don't consider themselves patients. Hence the slight amendment. So while these are well-known thoughts and ideas, they've been around for many years. It's still useful to have another look at them to see whether we have really been living up to these slogans. The control of the health and well-being of a person with diabetes is not just one thing, it's a group of things. It's a very complex jigsaw. Now, we've heard about the importance of blood pressure control. We've heard about the importance of lipid lowering treatment, about smoking and lifestyle, and to a lesser extent, we don't use aspirin as much as we used to. So, while these are all important, I will concentrate on this aspect, which is of great interest to many of the doctors involved in managing diabetes as well as the nursing practitioners. This is just to emphasize that treatment must be individualized. You can't just say the patient has diabetes, let's look at the guidelines and follow those. Each individual person will fit into a particular specific set of circumstances. The skill, if you like, the art of managing diabetes would be finding which rules, which guidelines, and which research to apply to the person sitting in front of us. The pharmaceutical chemists have produced huge numbers of molecules, all of which have some effect or the other on glycemic control. So we are spoiled for choice, particularly if one works in areas where there is no restriction on the use of different agents on cost alone. So which of these medications does one choose? That is the question, and does that change throughout? So there are several factors which determine this. Firstly, diabetes is not a static disease. Type 2 diabetes is a moving target. During the natural history of the disease, a single patient will undergo changes which make the treatment slightly different at each one. The priorities of treatment, for instance, change at diagnosis. As the disease progresses, they may get complications. And each of these complications may affect the treatment. And at some stage, one comes to a situation where one has to make a decision whether the side effects of treatment are worth the risks in terms of benefits gained, and that's when the quality of life becomes important. So at different stages of the disease, there will be different priorities. It is important to control the blood pressure, it is important to control the blood sugar, it is important to avoid smoking, it is important to exercise, it's important to pay attention to diet. But at some point, we will have to balance risks versus benefits. The first of these would be declining renal function. Diabetes is one of the commonest causes of renal disease, and indeed, over a third of the people with type 2 diabetes will have some form of impaired kidney function in the form of chronic kidney disease. A third. As people get older, whether they have diabetes or not, there is a decline in the GFR. So irrespective of the effects of diabetes, there will be a progressive decline in GFR, so that the older person who comes with diabetes, who might be treated with, say, glibenclamide, and they have been treated from the time they were 40, when they are 75 or 80, it just might be that their glomerular filtration rate has reached a level at which a renally excreted long-acting drug like glibenclamide may not be that safe. That would require change. In the UK, diabetes is the most common cause of renal failure. If they have renal disease, they will also have vascular risk. As the eGFR goes down, the risks of cardiovascular events increases. So in the management of this person with diabetes, purely with decline in GFR, the priority for managing cardiovascular risk has increased because they may be having comorbidities. And as we go along, I will explore some of the impacts of this on how we treat. So let's forget the cardiovascular risk for the moment. Let's just concentrate on declining renal function alone. But that would involve also taking into account the other features of this person. As I mentioned, age, whether they drive or not, occupation, their weight, and their liver function. Each of these will have a bearing. So we always advocate tight metabolic control. But certainly in the UK, if somebody has to drive for a living, the risk of hypoglycemia in a person who drives many miles might be very high. And at some point, we would have a discussion with the person, and that person would have to make up their mind on whether to change their employment or go for tight metabolic control. That is their choice. So if it's just renal function alone, I'm not going to dwell too long on this slide because I know that Mick showed the same slide yesterday. It is just to illustrate the point that very few medications can be used without dose alteration throughout the natural course of diabetes. So it begs the question, how often do we measure renal function? How often do we categorize our patients into what grade of CKD they have? Because we are really good at looking for microalbumin and starting them on something. But do we monitor them? So the importance of monitoring them is that decisions may be made to change the medication. The most important risk is the risk of hypoglycemia. And certainly I've done a lot of work in South Asia where glibenclamide is the most commonly available medication. The biggest risk there is hypoglycemia. So it's not uncommon for somebody to come to the doctor and say, I've been on this medication for so many years. Why do you want to change it to a more expensive one? But the reason is that it would cause hypoglycemia. It's best not to wait till the hypoglycemia comes up, but to look at the guidance on EGFR and change them to something safer. Similarly with metformin, there are cut-off points at which metformin should not be used. And Mick spoke about it yesterday, so again I've deleted my slides on that one. And when people are on insulin, don't forget that insulin is degraded by the kidneys. Reductions in the dose of insulin will be necessary. Hopefully, if that's done, it keeps the person out of the emergency department. So that's the kidneys. While diabetes may not have a major effect on liver function, liver disease can be common from a variety of sources. Certainly in the UK, alcohol is by far the commonest cause of this. And the liver has very important functions in glucose metabolism. And you can see that certainly in terms of prevention of hypos, somebody with an impaired liver function may be more vulnerable to hypoglycemia. So what are the liver disorders that can occur? Well, fatty liver disease is not uncommon with poorly controlled diabetes associated with severe insulin resistance, and that's high insulin requirements to begin with. So the factors to be taken into consideration here, again from the liver point of view, is they may have altered drug metabolism. So again, what drug do we give? Similar to the renal disease, dose adjustment is required. For many of us, these things are available in the institutional intranet or in little laminated slides available to us. So far, what are the learning points? Well, the management of type 2 diabetes becomes complex as the disease progresses. Liver and kidney disease is an important consideration, and where necessary, dose has to be changed. Now, how well do we do? So I'll rapidly take you through some of the literature on how well we do on these things. Do patients take the medicines we prescribe? What are the things that stop them from taking it? So first of all, HbA1c targets are not very well met. Certainly in Western Europe, and North America, where many of these studies were performed. But we know from the UK PDS that controlling the glycemic indices will improve outcomes, and that these outcomes will have benefits long after the intensive period is gone. So there is a glycemic legacy, if you like. We also know from these studies, the UK PDS and the Accord in particular, that if people have existing heart disease, tight metabolic control implemented soon after that can result in increasing mortality. So actually, paradoxically, we are saying, if they've got existing severe heart disease, go easy on the HbA1c. And these landmark studies actually showed that, particularly because UK PDS started very early in the natural history of the disease, the studies which showed increased cardiovascular morbidity all recruited patients with more advanced heart disease. So if the diagnosis is late, if the person comes from the cardiologist, perhaps we shouldn't be in such a rush to get that HbA1c down. Perhaps we should spread it out a little bit. And you can see the differences in the duration of disease. So based on diabetes duration, the cardiovascular risk burden increases. So in increased duration, there may be a case for going easy on how fast we achieve glycemic control. just skip this one. So the other thing that we come across is that we keep telling people to take the medicines until it stops working. So that's effectively what we do. We put them on one agent and then we wait for it to fail. So this is the traditional approach. And you can see that the HbA1c gradually rises, that's the red line. But being proactive requires us to counter this clinical inertia. The study by Brown and others showed that there is a delay in producing the most optimal treatment. So certainly in North America, and from the data from Kamlesh Tunti in the UK, as well as others, you can see that there is inertia on the part of clinicians. And this is the UK data. So in 80,000 people with type 2 diabetes, the time to intensification was so slow. So what do we suggest? Perhaps we should be more proactive, and we can flatten that HbA1c line to make sure that we maintain good control without having this up and down swing. But there are barriers to this. The two most important ones are patients don't like gaining weight, they don't like getting hypoglycemia, so their adherence is poor. So we have clinical inertia on one part and patients not taking the medication for various reasons on the other. So we have to balance these two. And they definitely do influence the way patients think. So what can we do? Well, we know from all these studies that they do not adhere to treatment, however much we believe that our patients do exactly as we say. But we also know that because of non-adherence, we get poor outcomes. So we have to work with these people to modify lifestyle as well as just taking the prescription medication to improve outcomes. So you can see the weight gain is common with many of the medications. And if they gain weight, their health status and health satisfaction levels are low. So how can we improve this? I will just move through those slides quickly. So if we look at hypoglycemia, if they are at high risk, perhaps we should target those patients for careful adjustment of their dose. So there can be patient factors, lifestyle risk factors, and medication risk factors. So if we were going to change these medications, what are the things we look at? Age, renal function, body weight, and that's where GLP-1 agonists come into their own. They do cause weight loss. And last but not least, think about the patient. So if we were going to ask for a tight metabolic control, those who are on your left, you will be looking for tighter targets. Those on the right, you will be relaxing them. And that would help improve adherence. So, in summary, what we would try to do is to consider the risks of diabetes therapy for each individual person and then balance that against the benefits. But this involves some discussion with the individual. So we need to have that discussion between the patient and the healthcare professional. And there's very good evidence from the behavioral sciences that this dialogue is useful. Because the person is asking these questions. So that's part of the doctor-patient interaction to ensure that they do have these understandings. If they don't like injections, they won't do it. So to sum up, I would say that there are the medications, the comorbidities, renal function, liver function, age, and patient preference. The other thing that needs to be modified is our attitude. So I will leave you with that question. Do we have the right attitude? Thank you.
Thank you very much for a wonderful expose and a very important message, the personalization of treatment. I'll start the question and then I leave the floor for further questions, if any. When do you think the guidelines and later on the health policymaker would include the quality of life? Because I was expecting, when you talked about personalization, that you mentioned the quality of life, and more specifically the quality, as an important factor which should have an impact on the choice of treatment, the policy making, the planification of therapeutic regimens.
I think I might be able to answer that question in my next talk, which is about how to make the policy clinically relevant. But there is a two-way process here. It's one thing for policymakers to say do that. But the more important thing for me is, as physicians, what do we tell the policymakers? The policymakers don't actually tell us what to do. At the end of the day, through our professional organizations, through our own culture and behavior and what our patients tell the policymakers, that makes the policy. So if we think that quality of life is important, we should be talking more to our patients. If our patients appreciate the value of quality of life, policymakers will actually listen. And in many countries where there is a centralized Ministry of Health, it is very unlikely that the ministry will take the initiative on saying quality of life is important. They have lots of other things to do with budgets, communicable diseases, and all the other problems that they are faced with. So I think as the diabetes community, it's up to us to set these standards. So the answer to your question comes back to us. We will need to practice this and make sure all our colleagues practice it, and then it becomes policy.
Thank you very much, Professor Fernando, for a very elegant presentation. And I like very much that treat the person, not the disease. It's actually the person who is suffering. It's not the disease who is suffering this manifestation. And yeah, I like very much that.
Well, I think that's important, because when you are seeing the patient or when your juniors come and talk to you, very often they use, I have a case of, and then it becomes an abstract theoretical problem which you are applying to. So if somebody asks you about the patient or the person, it is very rarely a personalized thing. It is about this person's HbA1c is this, these are the parameters, what do I do? So I think increasingly, certainly where I work, we tend to insist that they introduce the person, give their occupation, and give a little bit more narrative about personal details in that introduction before you seek advice. Perhaps that's something that changes culture, but I think actually it is a consequence of changed culture where doctors are trying to do that.
This is the reason why IDF changed the diabetic patient into a person with diabetes. This is the idea. Thank you very much, Professor Fernando.